We're continuing on with the last 11 slides of our respiratory anatomy. And this is the macroscopic anatomy. Here's the right lung and here's the left. As Chris is drawing on the board, the left has an oblique fissure and a cardiac notch. It's called that because the heart sits slightly to the left. The right lung has an oblique fissure as well, but it has an additional fissure, the horizontal fissure. So that means the right lung has 3 lobes. It has a superior, a middle, and an inferior. The left lung has a superior and an inferior. The widest part of any organ is called the base, and the most narrow part is called the apex. We know from living here in California that the apex of the mountain means the top. It's not really referring to the top of the mountain, it's really referring to the most narrow point. So in anatomy, apex does not mean top, does not mean superior. It means the most narrow part of that organ. We can also see on the next slide the hilum. Now, a hilum is just an indented region that allows blood vessels and the bronchi to come in and out of the lung. We saw a hilum also in the kidney, the entry point for the renal artery and exit point for the renal vein, and also for the pelvis leading to the ureter. These macroscopic structures that you can see are called lobules. They are like a hexagonal kind of shape on the surface of the lung, and our models do show that to you as well. From your A&P 1, you should know that there are membranes around each lung individually. There's one that is tightly adherent to the surface of the lung called the visceral pleura, and then there's one that is closer to the body wall called the parietal pleura. In between is a slit-like potential space, meaning it has the potential to actually expand and get bigger. This is called the pleural cavity, and it is filled with pleural fluid. It's just a very thin layer of fluid between the 2 pleural membranes. But that space can actually grow in the case of a person who has pleurisy or pleuritis. Those both mean inflammation of these membranes, and they could produce more fluid, and that space can actually get bigger. The patient who has that will complain of chest pain, and you might think, oh, it's a heart attack. They might think it's a heart attack, but your patient will actually sit in a certain position to reduce the frictional rub of the heart as it's going, it's pumping, and the lungs are breathing in and out for us. So they're going to sit kind of launched forward like this, and if you lean them back, they're not going to be as comfortable. Now, of course, we rule out an MI, a myocardial infarction, by doing an EKG and blood work. Of course we do. We don't just rely on how they're sitting. Now, when we get into our last 2 lectures for the respiratory system, I will tell you about an atelectasis, which basically means a collapsed lung. It can collapse because either air is in this potential space or blood. If it's air, it's a pneumothorax. If it's blood, it's called a hemothorax. And you're going to see in a future lecture that this means this slit-like potential space, that cavity, can actually, it's supposed to have a negative pressure, which means it holds the lungs to the chest wall. When we talk about the work of breathing, we will explore that more in great detail. From our trachea that we learned about last week, it branches into a primary bronchus, a left and a right. And then from there we get the bronchial tree, which means a primary bronchus splits into more secondary bronchi that are smaller, and they branch into tertiary bronchi that are more plentiful and also smaller. But those are still part of the conducting zone. Those structures shown here are not small enough to allow for diffusion. The membranes that are around them, the walls, if you will, around those structures are too thick with the cartilage, etc. And there's just not enough of them. Not until we get to the respiratory zone do we have small structures, thin distance for diffusion to occur, and a lot of them. Now we do have a lung model in our closet that does show the bronchial tree with the primary bronchi, secondary, and tertiary, and they are colored. I don't know if they're colored the same way, but let me find that. Last time I saw it was in ink. Is it this one? No, it was just doing this because it was just that. It was just. It's all colored. Let's try another cabinet. I thought I took it out. It says, Chris, you're going to want to look at this. All right, let's not waste time. I will keep looking for it. It's going to bother me. It's going to bother me. Okay, moving on. Let it go. Let it go. Again, we have primary bronchi that branch into secondary bronchi, shown here in this kind of blue purplish color, into tertiary bronchi, shown here in yellow, and then we have, quote, smaller bronchi. And the last part of the conducting zone, the last part, are the terminal bronchioles. Now we get into the respiratory zone. This is where we have an abundance of structures, multitude of them. They are thin enough in their anatomy to allow for diffusion of gases, oxygen and CO2. And the beginning of the respiratory zone is going to begin with a respiratory bronchiole, which will lead to this cluster here called an alveolar sac. And all of these little honeycomb areas are alveoli. And from the respiratory bronchiole to these alveoli, we have a duct, an alveolar duct. The anatomy of this structure is actually quite important. Most instructors describe the alveoli that are shown here as a cluster of grapes. And from the outside, it certainly does look like that. However, if I had some grapes here in front of you, could you or could you not pull off one individual grape?
Yes.
All right, so they're not attached to each other, are they? So I understand what professors are saying. However, they are not independent structures. They share walls. They also share an interalveolar pore, and they have something called interdependency. They rely on each other to inflate and deflate. When we talk about the work of breathing and pulmonary disorders, that anatomy is critical for you to remember. They are not individual alveoli. they share walls. They are connected. And this can be a problem or a help, but it's a problem when a person does not have enough surfactant. So again, we're going to talk about that. It could be an infant that doesn't have enough surfactant, but it also can be an adult. And that's something we call infant respiratory distress syndrome, IRDS, or adult respiratory distress syndrome, ARDS. And you're going to get a little bit of a history lesson when I tell you about surfactant and its discovery. Around the alveoli, we see our pulmonary capillary beds. And it's like a web around the alveolar sac. The respiratory zone itself, diffusing gases across the blood vessels into the alveoli for oxygen, or from the alveoli out to the blood vessels in the case of CO2, consists of 3 layers. And these 3 layers are going to sound very similar to our filtration membrane, where we had epithelium, a basement membrane or basal lamina, and then we had endothelium. This respiratory membrane is about 0.2 microns. It is the thinnest possible distance to allow for gas exchange. We have simple squamous endothelium from the blood vessels, those pulmonary capillary beds that are around the alveoli. We had a fused basement membrane, and then we also have the simple squamous epithelium of the alveolus. So right here, respiratory membrane, alveolar epithelium, it's type 1 simple squamous cells, fused basement membranes, and then the capillary endothelium, and you can see the red blood cell in there. Thinnest possible distance for gas exchange. Type 1 cells are the simple squamous epithelium that I had on the slide back there for you to identify. But there's also type 2 cells. And the type 2 cells are going to release or produce surfactant. And surfactant is like a detergent. It has a water-loving part to it and a water-hating part. It is hydrophilic and also hydrophobic. More on that chemistry and why it is so vital to us in the history lesson that I'm going to tell you and the science behind it. It really was a very exciting time for our country. There's a reason why when 2 scientists actually worked together to discover what surfactant actually was. And I have the paper on it if you want. It's actually a really easy to read paper and very descriptive, and it'll tell you the same thing I'm telling you. So here's the hilum, or hilus, depends on how antiquated your textbook is. It is a place, an indented region in an organ that allows components to enter or exit, like blood vessels. In this case, not just blood vessels, but also bronchioles. Now we forget that there are pulmonary arteries leading to the lungs, bringing oxygen-poor blood. We forget that the lungs also have their own blood supply. When it's their own blood supply, we're talking about bronchial arteries and veins. This was also probably something a little challenging for your head to wrap around when we learned about the blood flow through and out of the heart. And I said to you all, the heart chambers cannot collect oxygen from the blood inside the chambers. Rather, the heart has its own vascular system. It has the right and left coronary artery. Remember that? The circumflex, the marginal. So the lungs, they have blood vessels that are bringing blood to the lungs for the sake of gas exchange and taking it back to the heart. but they also have their own arteries and veins to bring them oxygen and nutrients and pick up CO2 and waste products. Sympathetic and parasympathetic. Those two divisions, if you're running for your life, you want your bronchioles, all of them, as much as you can, get them dilated. You're running for your life. You're running from a predator. You're sucking wind, as I like to say. But if you're resting and digesting and in more of a parasympathetic mode, those bronchioles can constrict. You don't need that much airflow anymore. You're just sitting here resting. Yes?
Just a question. What we were just talking about with the arteries and everything, is it this right in here?
Yes.
Okay.
Yes, it is. So let me show you. Okay. These this side versus that side. Pulmonary artery, blue. Paired pulmonary veins. Why are these not paired? I don't like this model. Why is it showing 3 paired on this side, nothing paired on that side? And there should be more blood vessels to show us the bronchial arteries and bronchial vein. So let me see if I can find another model and point that out to you, but I suspect that's as good as it's going to get. So we're going to deal with those as just pulmonary, not the bronchioles, or not the bronchial arteries. Respiration versus ventilation. Respiration means we're exchanging gases. There is external respiration, which means we're exchanging oxygen from the alveoli into the blood and CO2 from the blood to the alveoli. It's called external because your lungs, your trachea, all those air passageways are basically extensions of the external environment. That's how you bring the air in and push the CO2 out. Internal respiration means you're somewhere in a capillary bed in the body and you're having gas exchange again. Oxygen goes from the blood into the tissues and CO2 goes from the tissues into the blood. Cellular respiration is something that you learned in A&P 200, where we actually utilized oxygen as the final electron acceptor, and you learned about glycolysis and the Krebs cycle and the electron transport chain. Do any of you remember the story I told you for the electron transport chain? I took you on a trip to Chuck E. Cheese's, and I talked about the tickets that, someone remembers. Ventilation means that we're actually bringing air in and out of our lungs, into and out. If we are inhaling, that is inspiration, that's another name for it. If we're exhaling, it is called expiration, which is the reason why when we say, when was the expiration date? When did the patient expire? And that meant they let go of their last breath. What? You're laughing? I'm talking about a patient. But yes, you're right. Doesn't even really pay attention to that. I don't. I use my nose and my eyes like that. I don't care what the expiration date says. That looks like it's bad already. And then other times I'm like, it's not been opened. It's still okay. Yeah. Yep. Drives my housemates crazy. They're like, all of this is expired. Actually, no. It's because I buy stuff in bulk and then I transfer it to the container to refill it, reduce, recycle, reuse. Like, well, then how do we know it's, well, then buy your own. Problem solved. Okay, how do we breathe in? This is just a quick overview of that. We are definitely going to cover this step by step. Let me ask you a question first, something you should already know. How does blood flow? What is the driving force for blood to flow? High pressure to low, correct? How do you think air is going to flow? High pressure to low. And I'm going to ask you when I go through this step by step, how do you blow up a balloon? I just want you to think of that. How do you blow up? What do you look like when you're doing that? It seems so simple, isn't it? And yet, we inflate our lungs in the most arduous, difficult way. We use negative pressure breathing. More on that to come at a later lecture. For us right now, let's learn about the muscles of inspiration. The lungs are elastic structures. That's true. They are not muscular structures. They cannot change their volume on their own. That means they have to be anchored to the chest wall. That's why we have the pleura, the parietal and visceral. We have the diaphragm, which is the prime mover of respiration. When it contracts, it moves inferiorly. And this stretches the lungs so that they get longer. And that means their volume is increasing. Next, we have external intercostals and internal intercostals. External go from an upper rib, a superior rib, and insert on an inferior rib. Hands to pockets, as I like to say. Internal intercostals they have their origin on an inferior rib, and they insert on a superior rib. Hands to chest, as I like to say. So what muscles, minimum muscle contraction do you need? Normal, quiet inhalation requires ATP, requires muscle contraction. You need the diaphragm to contract and move inferiorly, and you also need the external intercostals, which help pull the rib cage open so it expands anterior and posteriorly. Those external intercostals also help the rib cage expand laterally, which is why you see a picture up here of a bucket, like a bucket handle. It can do this, right? And then you have room for your hand to hold on to that handle. So we need 3D expansion, longitudinally, anterior and posteriorly, and also laterally. If you want forced inspiration, deep inspiration, where you're like, then you recruit more muscles. You still need the diaphragm and the external intercostals. Students forget that. When I ask about deep inhalation, what muscles do you need? They totally forget about the diaphragm and external intercostals. You still need them, but then you recruit more. You have the scalenes that can also contract. You have the sternocleidomastoid muscle that you start doing this, trying to get more air into your lungs. You also use the erector spinae muscle. You start arching your back to help expand the lungs. Again, if you can expand your chest cavity, then the lungs have to expand as well. So scalenes, sternocleidomastoid, erector spinae, but also the pectoralis minor. For expiration, for quiet expiration, no ATP is required. Absolutely not. All you do is stop contracting the diaphragm and external intercostals. You let them just merely relax. When they do, the diaphragm comes back up superiorly, pushing on the lungs, making them have a smaller length, and the external intercostals stop pulling on the rib cage like this or like this, and so everything just goes back to its place. The lungs are elastic, and I have been telling you, what are the two important properties of elastic tissue? It can stretch, but the most important, recoil. Recoil. So it can stretch, but then like a rubber band, if you let go, it would recoil. But if you need forced expiration, then you recruit more muscles as well. You recruit contraction of internal intercostals. You also recruit your abdominal muscles. If you're recruiting those muscles to exhale, you are now turning a passive process into an active one. And I'm not talking about membrane transport, I'm talking about utilization of ATP. If you are really trying to exhale a lot, what position do you think a patient or you might take if you're trying to forcibly exhale? And I'll tell you, when we get to the work of breathing and we start talking about pathology of the respiratory system, there is a typical stance that a patient will take, and it's called the tripod. They'll put their hands on their knees like this. Have you ever seen someone on the field, the football field, whatever, and they're doing that? They're trying very hard to exhale. Something that should not require ATP, now they're working harder. That's what I mean by the work of breathing. Most of the time, we don't think of breathing as work because we really don't think about it. Inhalation requires ATP. Exhalation, if it's just quiet exhalation, no ATP required. If you have a patient that is now struggling and working to breathe on both ends, they are going to get exhausted. And the very things they need to do to help with that they're going to be tired. And the best type of person to represent that would be a premature infant, where they don't have enough surfactant. And it is awful to see them struggling to breathe and to also exhale. Also, people who struggle to exhale would be people with asthma, people with COPD. So asthma, COPD, chronic obstructive pulmonary disorders, there's the trifecta. There's asthma, chronic bronchitis, and emphysema. And I will cover all three of them and their unique features as to why the person has difficulty mostly with exhaling those. We do have, just like we learned in Unit 1, in the medulla, we do have, in addition to cardiac centers like cardio-acceleratory or cardio-inhibitory, we do have respiratory centers. And these respiratory centers are going to regulate your breathing rate and depth. But there are other parts of your brain that can also influence the medulla oblongata. And those other parts are the pons, but also the hypothalamus. If you get really scared, your breathing goes up. You get really angry, your breathing goes up, right? So your rate of inhale and exhale and how deep you're breathing in can be augmented by these other spots in the brain. We also have chemoreceptors, and they're found in the same place as the baroreceptors out here in the aortic arch and common carotid. Those would be called the peripheral chemoreceptors. They respond to changes mostly to oxygen. That is something else we have to really pick apart. You have central chemoreceptors that are found in the fourth ventricle, which is the ventricle that is bounded by superiorly by the pons, and then inferiorly by the medulla oblongata. And we will go through how they detect changes in CO2. Central, detect CO2 and respond very quickly to it. Peripheral, respond the most to oxygen, but it requires a huge change in the oxygen content in the blood. Again, to be continued, this is just mostly an overview. The pathology that I will cover with you in more detail, not just COPD with its trifecta, asthma, emphysema, chronic bronchitis, but I will also tell you about restrictive disorders. A person will position themselves in a different position depending on, is it obstructive or restrictive? And I'm going to tell you just a short answer before I go into it. Restrictive means the person has a problem with expanding the lungs. And I misspoke earlier when I said the premature infant would have a problem with exhale. No, they have no problem with exhalation. Their problem is with inhalation. Sorry for that. But I will certainly make a big notice of that when we talk about our pathologies. Cystic fibrosis, still restrictive, difficult to expand the lungs. A person with an obstructive disease has a problem with exhale. So that would be asthma, chronic bronchitis, emphysema. Problems with exhale, and think another X, exchange. So a lot more details coming with respect to those. Have a good day. Good work.